Welcome back. We are continuing our discussion today about the 2025 ADA Standards of Care, and joining us again is our favorite diabetologist, Dr. Amber Healy. No offense to other diabetologists in the world. And if you hear any strange beeping during this episode or the building begins to shake, it is not my brain or a CGM alarm. It is actually construction outside this building. So, with Dr. Healy, today we are going to talk about the classification of diabetes and the diagnosis. So, it's chapter 2 in the ADA Standards of Care. So, tell us what we're going to talk about first today, Dr. Healy.
Right. So, I recognize this chapter is diagnosis and classification of diabetes, but we're going to skip over the diagnosis part of this because you probably already are aware of that.
Okay.
Classification, our biggest focus will be on, when is that patient with type 2 really not type 2? Like, what should be your suspicion for type 1 diabetes? Because about a third of patients, and I've heard all the way up to 40% of patients actually, are misdiagnosed as type 2 when they really have type 1. So what are those clinical clues? And if you suspect it, what should you order to help you,
determine,
make sure that your suspicion is correct?
I think this is huge because I think to myself about how many patients we have who are diagnosed with type 2 and that A1C still runs so high. And if we are missing that diagnosis of type 1, that may really throw off numbers for patients who have type 2.
Yeah, well, and it's interesting because we tend to assume if the person sitting in front of you is overweight or obese, and we have an obesity epidemic, right?
Correct, right.
And your automatic is, well, they're obese, they have to be type 2, and, but that's not always the case.
Exactly. I love that.
So they have this really nice framework that they've started to use.
Okay.
And I'm going to cheat and look in the text a little bit.
Okay.
It's the AA, BB, CC, mnemonic, basically. So age. If the patient is under 35 and at their diagnosis, you should probably be more suspicious that they have type 1 rather than type 2. But put it in the framework of what else is going on with the patient.
Beautiful.
Autoimmunity. Do they have a personal history of other autoimmune conditions? So a lot of times the patient might already have like Hashimoto's thyroiditis, they have celiac disease, maybe they have rheumatoid arthritis or lupus, some other autoimmune condition to think about, or a family history of autoimmune conditions.
That's huge, right.
So, maybe they have a parent with type 1, maybe they have a parent with Hashimoto's thyroiditis, but if they already have another autoimmune condition in their family, you may want to consider looking for this diagnosis.
Okay.
The other thing that we look at is body habitus. Yes, I mentioned earlier on, if they're obese, but, definitely if the patient is on the thinner side, they have a BMI of less than 25.
Okay.
That's more consistent with a type 1 diagnosis. And then the background, we talked about family history already a little bit. Definitely family history of type 1. We know that there's some increased risk. We know if dad had type 1, your risk is 1 in 17.
Wow.
Mom had type 1, it's 1 in 25.
Wow.
They have these different statistics out there. So it's important to be mindful of that.
Okay.
And then control, and I know that control is kind of a bad word now. I mean, you have problems with the patient getting to their goal.
All right.
And a lot of times these patients have been tried on multiple oral agents.
Yes.
And no matter what they do, no matter what they're put on, they just can't get to that target.
Right.
So maybe it's time to consider that they really aren't type 2.
That's interesting. That's great.
And then the sixth point that they have is in the comorbidities, and this is a newer thought. Yes, we've talked about the autoimmune conditions as a comorbidity, but we have a lot of patients that are now getting immune checkpoint inhibitors for cancer.
Yes.
And it can induce an acute autoimmune diabetes. So like if you have a patient that's received chemo
Yep.
that includes one of those medications, you may want to go ahead and screen them for type 1 diabetes.
That is so interesting. I really love this. So in the text, I have noticed that it's on page S32 in the standards of care. It's the AABBCC, and it's age, autoimmunity, body habitus, background, control, are they at goal, and comorbidities.
Yeah.
That's fantastic. I think that's really helpful.
I do too. I was excited when I noticed it in the 2024
Yeah.
standards of care. So they brought it
Okay.
back. So
Okay.
they thought it was important enough to continue to have it in there.
I love it. We also talked about, sorry, I think you're going to say this too.
No, you go ahead.
The next thing we were going to mention too was antibody testing for differentiating type 1 from type 2. Would you like to tell us about that?
So they have a panel commercially available now of 4 auto antibodies that you can order for your patient that you're suspicious of this. And you know, everyone was aware of GAD65,
Yep.
the glutamic decarboxylase 65 antibody. We've known about that one a long time.
Yes.
So the GAD65 antibody is still included.
Okay, cool.
But since then, they've discovered more antibodies. So you're also able to get the zinc transporter 8 antibody,
Okay.
which is actually the second most common to find positive after GAD.
Wow. Okay.
They have also what is the islet antigen 2 antibody,
All right. Interesting.
which is actually like an antibody against like a tyrosine kinase that's involved in the islet.
That is so cool. Okay.
And then you can get an insulin antibody.
Okay.
And
I can see all the autoimmunity in there.
Yeah.
Okay.
well, and in general, you know, if a patient has 2 or more of these positive, it is definitely type 1 diabetes.
Okay.
You know, because there's even new guidelines out for early stage screening
Okay.
for type 1 in people that are more likely to be predisposed to having type 1. We mentioned some of those risks earlier.
Right. Absolutely.
So there, you know, 2 antibodies positive even now is considered stage 1 type 1 diabetes.
Okay.
So they definitely need the 2 antibodies positive in these folks too to really call them type 1.
That's really interesting to me.
But
think it's great.
but at the end of the day, I mean, you still think they need insulin to help them, even if you don't think they have type 1 or they don't look like they cleanly have type 1 or type 2, because they have a whole chapter on this classification.
Okay.
There's other types of diabetes. If insulin you feel is appropriate, just add it.
Just add insulin. That's fantastic. That's awesome. So there is a commercially available, I just wanted to revisit this for the providers that are listening. There is a commercially available panel that you can run that includes all these different tests for type 1 versus type 2.
Yeah, your hospital might have the panel built.
Okay.
Ours does not, so
Okay.
I actually have my own panel that I created, but those are
Awesome.
the antibodies that are commercially available
Okay.
that you would want to include in a panel.
Okay. I really like that. That's actually really helpful. We may revisit that sometime. That might be a really interesting discussion to have. So
Yeah, it might be exciting at some point to talk about early stage type 1 screening, because they do have guidelines out that came out and they were presented at the ADA this past summer.
that's awesome. This is really exciting. Awesome. Is there anything else that you wanted to share with us on the staging or classification of diabetes, or did we get all the points?
We covered all our points
Okay,
today.
fantastic. All right. This is really exciting for me. I really appreciate this. I think as a pharmacist, I think about the patients who come in and how many of them are on multiple oral medications for diabetes and wondering about that classification. So that's really helpful. Thank you, Dr. Healy, for your time today.
You're
Thanks,
welcome.
everybody. I'm sure we'll be back. We hope you have a wonderful day.